Good afternoon, everyone. Thanks so much for joining today. Welcome to the webinar, Substance Use and Communities of Color, co-hosted by the Office of Minority Health and the Substance Abuse and Mental Health Services Administration within the U.S. Department of Health and Human Services, also referred to as HHS. I'm Leandra Olson, and I'm the Policy Team Lead at the HHS Office of Minority Health, and I have the pleasure of serving as your moderator today. In the lead up to Minority Mental Health Awareness Month, today's webinar will highlight HHS resources and recent efforts to address substance use disparities in underserved communities. As you may know, people of color have more unmet needs for substance use disorder treatment services, and they experience worse outcomes when they access such services compared with non-Hispanic white people. So today we have an excellent lineup of experts from HHS to discuss how we are working across the department to address these disparities. Next slide, please. First and foremost, I have a few housekeeping items to go over. The opinions, findings, and conclusions expressed by speakers during this event are strictly their own and do not necessarily represent the opinion, views, or policies of the Office of the Assistant Secretary for Health, the Office of Minority Health, and the Department of Health and Human Services, as well as the Substance Abuse and Mental Health Services Administration. Nor does mention of trade names, commercial practices, or organizations imply endorsement. References to publications, news sources, and non-federal websites are provided solely for informational purposes and do not imply endorsement by the Office of the Assistant Secretary for Health, Office of Minority Health, U.S. Department of Health and Human Services, or Substance Abuse and Mental Health Services Administration. Those organizations assume no responsibility for the factual accuracy of the content of the individual organization found at non-federal links. Okay, now for more of the fun stuff. This webinar is being recorded and will also be posted to the Office of Minority Health YouTube channel for sharing. Real-time captioning and an ASL interpreter are available for those who need it. All participants will automatically be muted throughout the duration of this webinar, though participants will have access to the presenters and co-hosts via the chat box throughout the webinar. So if you have questions or comments, please feel free to leave those for us in the chat. We will have a few minutes for questions after our last presentation, but please feel free to submit your questions throughout the duration. Next slide. Our Deputy Assistant Secretary for Minority Health, Rear Admiral Felicia Collins, unfortunately could not join us today, as she is taking some well-deserved time away from the office, though she was able to record a brief welcome for you all. Could we please start the recording?
Hello, I am Rear Admiral Felicia Collins. Hello, I am Rear Admiral Felicia Collins. I have the honor of serving as the Deputy Assistant Secretary for Minority Health within the U.S. Department of Health and Human Services and the Director of the Office of Minority Health within the Office of the Secretary. It is my pleasure to join you today, and I am especially delighted to be joined by experts from across the U.S. Department of Health and Human Services. And to our audience, I thank you for joining us also. For those who may not be familiar with the Office of Minority Health, our mission is to improve the health of racial and ethnic minority and American Indian and Alaska Native populations through the development of health policies and programs that eliminate health disparities. We do not provide direct clinical or direct social services. Instead, we seek to identify and catalyze the sustainability and spread of policies, programs, and practices that are successful in reducing disparities and advancing health equity for the populations that we serve. The Substance Abuse and Mental Health Services Administration within the U.S. Department of Health and Human Services, known as SAMHSA, has reported that the risks of substance use, its consequences, and access to and use of treatment and recovery services differ by gender, race, ethnicity, sexual orientation, age, and other factors. Drug overdose data from the Centers for Disease Control and Prevention show troubling trends and widening disparities between different population groups. For example, in just 1 year, from 2019 to 2020, overdose death rates increased 44% for Black people and 39% for American Indian and Alaska Native people. Now, we know that culturally responsive healthcare improves both short and long-term outcomes for all persons, for all types of healthcare problems. Thus, to best serve racial and ethnic minority and American Indian and Alaska Native populations, it is so very critical that we design and implement effective, culturally and linguistically appropriate substance use disorder prevention and treatment programs. For today's webinar, we are delighted to have 3 great presentations. The first presenters are Annette Waters from the Office of Human Services Policy in the Office of the Assistant Secretary for Planning and Evaluation, and Juliet Bowie from the Office of Minority Health. They will share details on their report on meeting substance use and social service needs in communities of color. Next is Lisa Parker with the Office of Behavioral Health Equity at the Substance Abuse and Mental Health Services Administration. She will discuss how to create equity by developing a non-traditional workforce. And our third presenter is Nelia Nadal from SAMHSA's Center for Substance Abuse Prevention. She will share community engagement strategies for substance use prevention. In closing, I am confident that you will find today's sessions to be very informative. More importantly, I also believe for some, if not all, this webinar will spark new and renewed commitment around exploring and implementing strategies that support culturally responsive behavioral health care, which is so very important for the communities that we serve. Thanks again to each of you for joining us, and enjoy the webinar.
Great, thank you. As Rear Admiral Collins noted, we have an impressive presentation lineup with experts from across HHS for you all today. But since Rear Admiral Collins recorded those remarks, we have added a bonus presentation from Twyla Adams, who is an excellent addition to this panel. She will present on buprenorphine waiver changes for prescribers and the implications for racial and ethnic underserved communities. Twyla is a senior public health advisor within SAMHSA's Center for Substance Abuse Treatment. I will now turn it over to our first presenters, Juliet Bowie from the HHS Office of Minority Health and Annette Waters from the Office of the Assistant Secretary for Planning and Evaluation. Thanks.
Thank you, Leandra, and hello, everyone. I am so grateful to be with you in this virtual space and with my wonderful colleague, Annette Waters, to share about an OMH and ASPE project, which would not have been possible without OMH's partnership with ASPE's Office of Human Services Policy, without the hard work of an amazing research team from the Urban Institute, and most importantly, all of the knowledge that was shared by community leaders and practitioners. Next slide, please. So this project was first conceived several years ago when we were seeing the devastating effects of the opioid crisis, and in particular, growing disparities that were experienced by communities of color. But we know that these disparities were around well before the crisis and extended beyond opioids to substances in general, and that people of color lacked access to effective substance use disorder treatment and supportive services to address social needs. Despite these gaps, there was limited research about what works to address inequities in treatment access and outcomes. Next slide, please. So a multi-part study was conducted to learn more about substance use and treatment disparities and about effective approaches for addressing substance use and social service needs in communities of color in a culturally and linguistically appropriate manner. So in today's presentation, Annette and I will highlight some of the findings from that study with a focus on what was learned through interviews with community leaders and practitioners about how they provided services effectively to diverse populations in their communities and about the challenges they faced in doing so. I'll now turn it over to Annette to share about common approaches that community providers used in supporting culturally and linguistically appropriate care.
Thank you, Juliet.
Next slide. So in our research, we looked at common approaches of the programs in our research to look at how they met the needs of communities of color. And they centered and reflected the community in their staffing and services. So the people who were in providing services, so people who were providing services could see themselves reflected. They offered comprehensive holistic care, they used harm reduction and healing-centered approaches, and they incorporated culture into the organizational structure and treatment models. Next. These programs also centered and reflected the community in their staffing and services. And here's a quote I'd like to read to you all. Our program really works well because it was made specifically for our demographic. In our community and the things that we saw culturally in our community, you may take this and put it somewhere else, and it may fail because it was not meant for that community. Next. In terms of holistic care, this is another quote. We're helping organizations. That's it. That's the core of any ethnic service, ethnic community-facing organization. We become masters of everything. It makes me chuckle these days because the term of the last decade has been integrated care. What is there to integrate? We've been doing everything from the very beginning. Next. These programs also used harm reduction and healing-centered approaches in delivering substance use treatment. And this is another quote. We don't just believe in trauma-informed practices. We live trauma-informed practices. We treat everyone with extreme welcome and friendliness and understanding and empathy. When they walk in our doors, they feel treated like a human being, sometimes for the first time. Next. These programs incorporate culture into the organizational structure and treatment models. And here's another quote. There are oppressors in our society with respect to race, ethnicity, language, and gender that obviously impact our client populations. But we find that the stigma around addiction can be one of the most impactful. Often, we're one of the few programs, facilities, people can reach out to our clients from a place of respect and appreciation for who they are as a whole person. Next. Now, the programs also face some constraints. There were structural barriers in terms of limits on resources and the ability to address social needs. There were challenges maintaining staff with language and cultural skills, and this was particularly the case during COVID when our research was being done. And there were numerous funding challenges. There was also a lack of program evaluation data, which made it very difficult for programs to know for certain whether particular practices and approaches were working. So there's a strong need for more evaluation of these programs. I'd like to turn it back over to Juliet.
Thank you, Annette. Next slide, please. So addressing social needs like housing, childcare, and transportation is a really important part of being able to successfully treat substance use issues. However, interviewees shared with us that structural barriers like systemic racism and a lack of investment in diverse communities played a major role in limiting the resources that were available to address these social needs. Next slide. The interviewees also reported experiencing challenges with retaining staff who had the language and cultural skills to best serve the populations in their community. And these challenges included not being able to offer competitive salaries and the limited availability of individuals with language and cultural skills. Next slide, please. They also reported encountering various challenges with securing adequate funding to support comprehensive and holistic care. And this included inadequate federal, state, and philanthropic funding, and numerous funding gaps for certain services and populations. So as a result, There was a constant need to fundraise from various sources, and this caused an administrative burden for the organizations. Having to patchwork funding sources also hampered the creation and maintenance of fully integrated clinical and social services and supports. Next slide, please. Finally, as Annette mentioned, interviewees reported having limited resources, bandwidth, and expertise to track metrics and to evaluate program effectiveness, information that could help them not only improve their services, but also build the business case for further funding. Next slide, please. So those were just a few highlights from the study, and we want to invite you to check out the issue brief, which is available from the ASPE website to find more information on this study and its findings. Our hope is that folks will be able to use what we learned to help inform policy and practice, to address substance use disparities, and to help advance equity for communities of color. So thank you so much for your time. And it's now my honor to pass it to our next presenter, Lisa Parker from SAMHSA's Office of Behavioral Health Equity.
Good afternoon, everyone, and thank you for having me. I'm going to talk a little bit about workforce development, but I'm going to begin by looking at how we got to this moment in time where we're talking about opiate overdose deaths amongst communities of colors. Next slide, please. The rise in opiate-related overdose deaths can be outlined in three distinct ways. The first wave began with the increase in prescription opiates being given out during the early 1990s. The second wave we can look at happened around 2010 with rapid increases in opiate overdose related deaths involving heroin. And at that time, we started seeing an increase in the number of Black Americans experiencing opiate related deaths. The third wave happened in 2013 with significant increases in opiate-related deaths involving synthetic opiates, including fentanyl, particularly those illicitly manufactured. The market for illicitly manufactured fentanyl continues to change, and it can be found in a combination of drugs, including heroin, marijuana, as well as other street drugs. Carfentanil, another member of the fentanyl family, is also something that we're seeing in the community. We're seeing an increase in those carfentanil-related deaths, and we have to keep in mind that carfentanil is more potent than heroin. Next slide, please. The issue brief completed by the Office of Behavioral Health Equity highlights promising and effective key strategies being used in Black communities as well as Latino communities specific to opiate overdose disorders. As we heard a little bit earlier, it's important to look at the cultural factors that increase individuals' risk for potential opiate-related overdose as well as other substance use issues. Next slide, please. Key findings from the issue brief: synthetic opiates like fentanyl became the leading cause of opiate-related deaths in 2017, accounting for nearly 70% of all deaths. To date, overdose death rates and the number of drug overdose deaths per 100,000 people has increased 44% for Black communities and 39% for American Indians and Alaskan Natives. People compared to 2019, according to new CDC vital statistics. Next slide, please. And again, this gives you a greater understanding of what the misuse and opiate-related deaths data look like during 2018 and 2021. And we continue to see a significant increase in opiate-related deaths post-COVID, specifically among African-American men and Indigenous populations. Next slide, please. A history of substance use in Black community is considered common, but a history of receiving substance use treatment is not. Higher availability of treatment services does not mean improved access to care. The difference in access is related to barriers to care, and healthcare mistrust play a big role in inequity, with Black and Latino communities seeking access to treatment. So as we look at, again, the increase in deaths related specifically among Black and Latino and Indigenous populations, we have to be mindful that a lot of the treatment service providers, a lot of treatment programs don't necessarily reflect them culturally or ethnically. Next slide, please. So recent studies show that that members of Black and Latino and Native American populations experience less favorable outcomes when it comes to retention and completion of substance use treatment. In order for change to happen, we have to pay attention and understand the complex factors impacting substance use in African American, Latino, and Native American communities. It's important we understand how substance use and abuse differs between racial and ethnic groups. Substance use is, in most cases, a coping mechanism for minority communities. It's an escape. It relieves anxiety. It helps someone dealing with depression. And we also have to think about post-COVID, the trauma that a lot of these communities have experienced financially, as well as within their relationships within their families. Next slide, please. We also have to look at systemic barriers. For Black Americans and other minority communities, the criminal justice system represents a barrier to treatment for those living with substance use and mental health related issues. In most cases, Black Americans caught with drugs are incarcerated and face longer sentences versus their non-Black counterparts. Individual barriers such as lack of employment, housing, or health insurance are also barriers to treatment for Black and minority communities. Most cases, members of minority communities will access publicly funded treatment programs, which typically come with long waiting lists, requirements for detox prior to admittance, and proof of insurance. Whereas private treatment programs typically have lower barrier requirements for admittance and have more client-focused approach towards service delivery. Next slide, please. So what we can do to improve outcomes and retention for Black and other minority communities, we can begin to understand again the cultural and ethnic differences in service delivery. We can actively include people who use drugs and experience marginalization for their expertise when developing new programs or evaluating or duplicating current successful community-based practices. We can emphasize building relationships and trust with people who use drugs as important outcomes. We can consider how past histories of trauma, violence, layers of disadvantagement, and stigma may have affected a person's ability to engage and succeed in treatment and recovery. We can ensure services are grounded in an understanding of how people's health priorities and experiences are shaped by the criminalization of drug use. We can ensure all services are provided in a culture of respect and safety, and we can review documents and materials to ensure that people first language is being used. We need to make sure that as we're giving information, as we're addressing stigma and barriers, that again, we have equal language access for those people who may not speak English as a first language. And again, we also want to look at a non-traditional workforce, creating opportunities for individuals who are peer support specialists, community health workers, mental health advocates to take a lead role in reaching out and ensuring that community members have low barrier access to treatment and other recovery services. Next slide, please. Finally, again, tailoring strategies for diverse, homogeneous communities to address the opiate crisis is important. Acknowledging and addressing contextual issues, barriers. And again, making sure that our strategies, our policies, and our funding opportunities support non-traditional communities and are culturally appropriate. We also want to engage in interdisciplinary, multi-level collaborations. It's important in this moment in time that we make sure those of us working in federal government reach back to local communities and again, increase their efforts and their capacity to assist, to access funding opportunities as well as training and other capacity building assistance. Next slide, please. Finally, I want to offer some resources, SAMHSA publications and resources. The Net Learns, the Office of Behavioral Health Equity also has the Elevate CBO project and other resources around data and again, increasing access for community-based organizations to have the ability to increase their reach in the community. Next slide, please. And again, additional resources for programs and practitioner training. Right now, I'd like to hand it off to Nalia Nadal.
Thank you, Lisa. Hello, everyone. I'm pleased to join my OMH and SAMHSA colleagues today. My remarks are going to focus on community engagement for substance use prevention. It's an important tool to improve the health of the community and its members. Next. SAMHSA uses engagement strategies to promote broad-scale adoption and implementation of effective prevention interventions. When interventions don't fit the needs of a specific population, community engagement facilitates the development of appropriate approaches to meet a community's needs. To help states and communities refine their engagement work, this particular guide was developed under the leadership of SAMHSA's National Mental Health and Substance Use Policy Laboratory, together with CSAP. Next. So let's start with the basics. What is community engagement? Essentially a process to develop relationships with stakeholders to work together in a collective fashion. It's based on 7 core principles, which range from transparency and trust to sustained engagement and participatory culture. Benefits of engagement. You learn what's working, what's not working within a community in terms of behavioral health. You can ensure meaningful involvement of community members who have a diverse range of knowledge, experiences, cultures, and perspectives that will be valuable in shaping what you do in a community. And it also helps demonstrate accountability to the community as to what you're doing. Next. This slide highlights SAMHSA's prevention role. Data show that most people with mental health and substance use conditions first manifest signs early on, childhood, adolescence, and young adulthood. So SAMHSA's model for supporting the scaling up of evidence-based practices is the strategic prevention framework. Essentially, strategic planning, it's grounded on community engagement principles. Next. So the challenge in prevention, and as in other fields, is being able to scale up implementation of things that work well. Community engagement is key to making this happen. Next. So nothing happens in a community without trust. Process of establishing trust starts with dispelling myths, honestly acknowledging community members' shared traumatic history, structural racism, and any other trauma that has been experienced in a community. When distrust exists, we need to promote healing and reconciliation in order to develop lasting, meaningful, trusting relationships. We do this by actively seeking information, visualizing what needs to change, and engaging in shared learning. Formally acknowledging a community's shared traumatic history is a fundamental step in preparing for and planning community engagement efforts that address health inequities. Next. This slide lists the types of community engagement activities found in substance use prevention. As you can see, community engagement supports planning and implementation, enhancing community buy-in, and increasing the likelihood of the services that you've put into play will continue on. Community engagement is context specific. When you've seen one community, you've seen one community. Engagement informs our actions. Next. Won't spend too much time on this. These are the affiliated outcomes that have been indicated as a result of doing community engagement. And so you can see that results were seen at implementation, service level, and individual levels. There are issues with attribution because there's no single engagement activity that would be responsible for achieving these outcomes. Next. The next 3 slides highlight key considerations and strategies for incorporating community engagement. I'm going to go ahead and go through these very quickly because I'd like to make sure there's enough time for questions and giving Twyla adequate time to go ahead and present her part of it. So these things are found in the guide, and this particular one just covers making community engagement a priority and obviously addressing diversity, equity, inclusion, and accessibility. All of those 4 things are a large charge in terms of something for communities to address. And so their equal care needs to be given to each of them. Next. This one looks at learning from other communities. There may not be anything in the research that actually covers what you need to try to do. So finding other people who have similar situations, learning what they've learned from life experience can be helpful. And then making sure you have the capacity to go ahead and do engagement successfully, making it part of your strategic planning. Next. And the last set of strategies relates to sustainability. If you do community engagement, what are your practice standards? How are you measuring the quality of what you're doing? And if you are ensuring that you've got community involvement at all stages, whether it's planning, data analysis, interpretation, implementation, every place that you can go ahead and pull that community in to work with you, the better. Next. In the community guide, there are 3 case studies. I encourage you to learn how engagement was conducted in these 3 different settings. So these are the extended stories. There are a number of other examples within the guide that give you a good handle on different ways that engagement has been carried out. So engagement involves different sets of activities, each aligned to the goals of the specific community and prevention interventions. Now I'd like to walk through an example of how SAMHSA is putting community engagement into action. Next. So what do we know about substance use in communities of color from the 2021 National Survey on Drug Use and Health? Let's look at the data for past month's substance abuse by individuals 12 and older. Top 3 substances being used in the general population, all 4 ethnic racial groups, and multiracial populations came out in order of use. Alcohol is number 1, tobacco products number 2, and marijuana number 3. For Native Hawaiians and other Pacific Islanders, data showed a slightly different order, but alcohol was still number 1, marijuana was number 2, and vaping nicotine was the 3rd. And as you can see, alcohol is the number drug of choice for all populations. Okay. So alcohol is one of the leading causes of preventable deaths and should be a priority for interventions and policy efforts. The Talk They Hear You campaign is a valuable resource for communities to support youth and families. So who's the campaign for? Talk They Hear You provides parents and caregivers, schools and educators, and communities tools and resources to have conversations with kids under 21 early on and often to prevent underage drinking and other drug use. It's currently in its 10th year. And it's run by SAMHSA, but the campaign's guided by 23 members of an interagency coordinating committee for the prevention and reduction of underage drinking, also known as ICPUD. Bad acronym, but it's an amazing group. So the campaign's different from other campaigns you may be familiar with. For several years, the ICPUD has worked to align public health messaging with early interventions as part of its work. So here's how that plays out. For anybody who's interested in taking a look at the campaign, community engagement guides everything we've done to date on this campaign as far as what's been developed for the field's use. So the simple way of calling out the goals of the campaign are, we want parents, schools, and educators and communities to be able to get informed, be prepared, take action. That pretty much would probably apply to anything any of us are doing out there. But in terms of an example, when we talk about get informed, Before talking with youth about substance use, it's important to know your facts. We have over 400 core publication resources available. Being prepared. We know information alone doesn't change behavior. There are tools to help parents practice their skills, to have those everyday conversations. For schools, there are tools to help them implement student assistance. For communities, we have campaign implementation tools. The campaign provides a really sound foundation for parents, schools, and communities to take action. Next. So there's one campaign resource I'd like to offer for your consideration to incorporate into your work with communities. If you're not specifically focused on substance use, this is actually applicable to other related areas. So this is the campaign's Screen for Success tool, which is available via the Talk They Hear You mobile app. Screening serves as a fast and easy way to identify areas that may benefit from more support, and it allows parents and others to meet youth where they are. Next. So this slide goes a little deeper into the domains addressed in the screener. Screen for Success is a multidimensional screener, and it does not provide a clinical diagnosis. It looks for elevated risk related to a variety of areas, and you can see here under the health, wellness, and well-being what those topic areas are. It's a tool worth exploring for your community health programming. So in closing, I'd like to ask you to do two things. We all do community engagement at some level. We know engagement is necessary to advance the uptake and sustainment of what works. So download SAMHSA's Community Engagement Guide. As a CBO, you can use the guide's content to help justify funding requests for community engagement, and the guide can serve as a training resource and a job aid for staff as you refine your engagement strategies. Second one is download the Talk They Hear You mobile app and try out the Screen for Success tool. It's currently available for individual use. It's confidential, free of charge. We're about to pilot test an organizational version this fall for organizations interested in using the screener for broad implementation. Next. Thank you very much for your time and attention. And I'd like to now pass it on to my CSAT colleague, Ms. Twyla Adams.
Thanks so much, Nelia. Good afternoon, everyone. My name is Twyla Adams, and I'm a Senior Public Health Advisor in the Substance Abuse and Mental Health Services Administration Center for Substance Abuse Treatment. Topics that I will cover in today's presentation include health disparities and inequities in overdose deaths, the history of the Data 2000 waiver for buprenorphine prescribing, recent legislative changes that removed the Data 2000 waiver, and some activities that the Substance Abuse and Mental Health Services Administration is carrying out under the Department of Health and Human Services overdose prevention strategy that, when coupled with these recent legislative changes, can minimize the impact of barriers that racial and ethnic underserved communities face when accessing treatment for substance use disorders. Next slide. I would like to begin by focusing on the overdose crisis, given the unprecedented and tragic loss of life facing the United States from fentanyl-driven overdoses and increasingly stimulants, as this slide shows. Exacerbated by the COVID-19 pandemic and the associated isolation, increased stress, and anxiety experienced by so many, addressing this crisis is a primary focus for the Substance Abuse and Mental Health Services Administration. Next slide, please. When we dig deeper and analyze overdose deaths, significant health disparities and inequities are revealed. In a 2022 Centers for Disease Control and Prevention report, it was found that from 2019 to 2020, drug overdose death rates increased by 44% among non-Hispanic Black persons and 39% among non-Hispanic American Indian and Alaska Native persons. The CDC report also stated that most people who died by overdose had no evidence of substance use disorder treatment before their deaths. These troubling overdose trends underscore the need These troubling overdose trends underscore the need for increased access to treatment services, particularly in racial and ethnic underserved communities. Next slide, please. Multiple studies spanning over 2 decades have demonstrated that increasing access to methadone and buprenorphine saves lives and reduces other healthcare costs in conjunction with other comprehensive treatment strategies. Mortality studies have shown the positive impact of expanding treatment with these medications for opioid use disorder, resulting in a 37% to 80% reduction in overdose mortality. Furthermore, a study of Medicaid beneficiaries with opioid use disorder found that substance use treatment incorporating medications is associated with reduced inpatient hospital admissions and outpatient emergency department visits. By promoting the expansion of methadone and buprenorphine treatment, we can improve outcomes for individuals with opioid use disorders and help save lives. So for the remainder of this presentation, I will primarily focus on buprenorphine. Next slide, please. I will begin by highlighting a few critical junctures in the history of prescribing buprenorphine. In November 2000, the Drug Addiction Treatment Act was signed into law, allowing physicians to apply for a waiver to prescribe buprenorphine for the treatment of opioid use disorder outside of an opioid treatment program. Waivers were obtained after taking an 8-hour course from an approved medical organization and otherwise approved by the Secretary of HHS. The waiver allowed physicians to treat up to 30 patients with buprenorphine. In August 2005, the patient cap was increased from 30 patients to 100. In July 2016, Section 303 of the Comprehensive Addiction and Recovery Act expanded the definition of a qualifying other practitioner beyond physicians to include nurse practitioners and physician assistants who meet certain criteria. This prompted HHS to issue a final rule to allow eligible prescribers to treat up to 275 patients. In 2018, Section 3201 of the Substance Use Disorder Prevention that promotes opioid recovery and treatment for Patients and Communities Act permanently allowed nurse practitioners and physician assistants to prescribe buprenorphine and further expanded other qualified practitioners to include clinical nurse specialists, certified registered nurse anesthesiologists, and certified nurse midwives until October 1st, 2023. In April 2021, the Secretary of HHS signed the buprenorphine practice guidelines, which exempted eligible practitioners from federal certification requirements related to training, counseling, and other ancillary services that are part of the process for obtaining a waiver to treat up to 30 patients with buprenorphine. Next slide, please. This past December, Section 1262 of the Consolidated Appropriations Act of 2023 removed the federal requirement for practitioners to have a waiver to prescribe medications like buprenorphine for the treatment of opioid use disorder. The provision was effective immediately, and SAMHSA stopped accepting waiver applications. All practitioners who have a current DEA registration that includes Schedule III authority may now prescribe buprenorphine for opioid use disorder in their practice, if permitted by applicable state law. This change is known as the Mainstreaming Addiction Treatment Act. Since December, it has significantly expanded the number of practitioners who can prescribe buprenorphine from 130,000 to 1.8 million. The act also requires the submission of a report to Congress in 5 years that assesses the impact of the elimination of the waiver program. SAMHSA and DEA are actively working on implementation of a separate provision of the Omnibus Act, the Medication Access and Training Expansion Act, also known as MATE, which requires that beginning on June 27th, 2023, practitioners applying for a new or renewed DEA registration will need to attest to having completed a total of at least 8 hours of training on opioid or other substance use disorders, as well as the safe pharmacological management of dental pain. So these two acts, they were critical. And when coupled with activities under HHS's overdose prevention strategy, can minimize the impact of barriers that racial and ethnic underserved communities face and increase access to substance use treatment and recovery support services. Next slide, please. Under HHS's overdose prevention strategy, there are an array of department-wide activities to increase access to the full range of care and services for individuals who use substances that cause overdose. Since its start in 2021, the strategy prioritizes 4 key target areas: primary prevention, harm reduction, evidence-based treatment, and recovery support. Next slide, please. Within the area of evidence-based treatment, some activities administered by SAMHSA Center for Substance Abuse Treatment to increase access to substance use treatment in racial and ethnic underserved communities include the Minority AIDS Initiative that increases engagement and participation in treatment, tribal opioid response grants that increase access to medications for the treatment of opioid use disorder and supports comprehensive substance use treatment in tribal communities, the National American Indian, Alaska Native, and Hispanic Latino Addiction Technology Transfer Centers that develop and strengthen the workforce that provides substance use disorder treatment and recovery support services in those populations. Provider clinical support system that trains health professionals to provide medication-assisted treatments to patients in multiple settings, and the Healing Communities Studies that helps communities in New York, Massachusetts, Kentucky, and Ohio to implement substance use treatment for opioid use disorders and reduce other harms associated with opioid use. Before concluding this presentation, we are reminded of the importance of addressing the substance use disorder treatment barriers that racial and ethnic underserved communities face to improve outcomes. Next slide, please. Some of these barriers include lack of insurance, transportation, accessibility in the community where one resides, childcare, and language translation. Additionally, persistent cultural barriers and beliefs exist, such as general mistrust of methadone and needle and syringe exchange programs in some Black communities. Evidence suggests negative stigma associated with methadone treatment when compared to buprenorphine. Historically, buprenorphine was not available to individuals that did not have private insurance or private physician, which limited access to many Black Americans with opioid use disorders. I will conclude by emphasizing that as the recent buprenorphine changes in HHS's overdose prevention strategy are implemented, these barriers must be addressed to improve outcomes. And moving forward, SAMHSA will collaborate with its federal partners to monitor the impact of the recent buprenorphine legislative changes, coupled with its own activities to increase access to substance use disorder treatment and recovery support services in racial and ethnic underserved communities. I thank you for your attention and look forward to responding to any questions.
Great. Thanks so much to our presenters for those really engaging presentations. We now have a few minutes, maybe about 8 minutes or so for questions and answers. So I know we have been getting some in the chat already, so please bear with us as we try to go through those. But please feel free to enter your questions for our panelists into the chat. And if possible, if you know which presenter the question is directed at, that would also be helpful. So our first question is for Nelia from SAMHSA. Can you please share if the Screen for Success tool has been used with all school-age children or just older children, young adults, 12 and over?
The screener is based on the GAIN SS, which I believe is the global appraisal of individual needs. And since I'm probably not the one to answer all the detailed questions about what's under the hood, it is something that is a validated screener. So if anybody's interested in having a follow-up so we can give you more detail as to what domains have been selected and placed within the screener and how it's intended to be used, or any of the technical details, if you're really serious about applying it. And even if you're not going to use it at an organizational level, it is available for individual use, and it's one way for you to go ahead and at least become a little bit more familiar with it if you decide to go further.
Great, thanks, Nelia. Okay, our next question is for Twyla. Does SAMHSA currently have any naloxone or buprenorphine distribution programs for communities facing high rates of overdoses?
I'm sorry, can you repeat that question, Leandra?
Absolutely. Does SAMHSA currently have any naloxone or buprenorphine distribution programs for communities facing high rates of overdoses?
Yes, actually, we do have several grant programs. And I would be happy to send the person who's posed that question information about those grant programs. So if you can put your information in the chat box, I would love to follow up with you.
Okay, and this one, thank you, Twyla. This one, Twyla, you might be able to answer as well, but others from SAMHSA, but this is a great question. We are hearing from clinicians in maternal health that removal of the 10 waiver has not increased the numbers of OB trained medicated assistant treatment for OUD providers. Does SAMHSA collect the breakdown of the types of providers using the waiver removal increased among those?
We are tracking that information, and actually we're out doing a lot of marketing and promotion to try to get more practitioners who are eligible to actually prescribe buprenorphine, but we are tracking that information.
Great. Okay, let's see, we're getting lots in the chat. Okay, I see some of you are interested in the grants. Okay, so this one is for Juliet and Annette. I'm just curious if you can briefly share about how participants can apply the information from your presentation to help further move the needle in addressing substance use in communities of color.
Okay, I can take on that one if that's okay, Juliet. What we need to do is get this information into the hands of people who are in the field, because I'm sure they're thinking about these things, but don't know how to necessarily come up with culturally specific practices that would address the needs in their community, right? So just getting the information into the hands of substance use treatment providers would go a long way. Making sure that schools have this information, community-based organizations have this information, community organizers have this information. So that, I mean, this is just one brief. We have a suite of briefs that will be coming out from this work, but just getting the information into the community so that people know that this is another, it's not even a tool in the toolbox. We need to structure programs that meet the needs of the local communities that access the services.
And Leandra, if you don't mind, I do want to take some time to make a plug for some OMH resources. So as it pertains to resources to support the provision of culturally and linguistically appropriate services, which you know is key to addressing disparities in communities of color. I want to invite folks to check out our Think Cultural Health website, and I'll drop the link in the chat momentarily, and the National Standards for Culturally and Linguistically Appropriate Services in Health and Healthcare, which is a framework that provides a blueprint for professionals and organizations to provide culturally and linguistically appropriate services. On the Think Cultural Health website, we offer a free accredited e-learning program specifically for behavioral health professionals. And we also have a guide that we produced in partnership with SAMHSA on specific strategies for implementing the national class standards in behavioral health settings. So just some resources to help think about how to provide culturally centered care.
Wonderful. Thanks, Juliet. Thanks, Annette. Nelia, I have a question for you. In one of your slides, you mentioned only a small group of communities had implemented the EBS model. Can you be more specific on any issues or constraints on implementing this model in minority communities?
Could you repeat that last part? Which model are we referring to?
The question in the chat says the EBS model.
Oh, just in terms of doing evidence-based practices.
And it says, can you be more specific on any issues or constraints on implementing this model in minority communities?
Not entirely sure I'm super clear on exactly which model, but I think the whole topic of community engagement was intended to help states or anybody who's going into a community to deliver services to make sure that you're attending to all of the needs of a community. So you're not just dropping something in there without being respectful of whether it's the right approach, the right setting, there's receptivity, capacity. So I think the guide actually covers a lot of the considerations when you're trying to go ahead and get something implemented at a local level. That it's not the here, just do this, without having any consultation with the folks that are supposed to be able to take advantage of it or to implement it.
Thanks, Nelia. And then our last question, and this, I'll invite anyone from the group to jump in because I think several of you might have some thoughts, but one participant noted that enrollment in treatment has layers of risk for the enrollee, risk for criminal justice and child protection systems. Do you have any suggestions on how we can move towards treatment as not being a risk for legal and punitive measures or barriers to care?
I'll try to give a response. I think one of the things that we have to do, and this is experience working with the Baltimore City Syringe Exchange Program, is have ways to develop better relationships and training opportunities for local law enforcement. I think taking a national approach to developing curriculums, creating funding opportunities where community-based service providers and community-based organizations can offer firsthand training around harm reduction, the importance of the police force being equipped to carry naloxone on a regular basis and having access to those critical harm reduction skills and resources would also be a big help in decriminalizing and making it less scary, so to speak, for community members to seek out treatment without the fear of being arrested or, again, being disconnected from their families.
Thanks so much, Lisa. And thank you, everyone, for being so engaged and sending some thoughtful questions in the chat. In closing, on behalf of HHS, I would like to extend a big thank you to our presenters and all of you for joining today as we work together to address disparities and support people with substance use disorder in communities of color. For those of you interested, the recording of today's webinar will be posted on the OMH YouTube channel in case you would like to share it with colleagues or use it for your future reference. And I'm happy to put the link to OMH YouTube in the chat for everyone to see. But thank you again for joining today and take care. Enjoy the rest of your week. Thank you.